Yeah, good afternoon everyone. So we will be having a session on MIGS. So we have a star team of MIGS surgeons, the angle surgeons here. So Dr. Neetu Mohan from Arvindai Hospital, Chennai, Dr. Bindu from Comtress, Dr. Mahesh is here. Okay, Dr. Mahesh from Ahalya Palakkad, he's just here. Dr. Lopamudra from Trivandrum, and myself, Dr. John from Cochin. So glaucoma surgeries have been evolving very rapidly recently. Until maybe 10 years back, most of the surgery for glaucoma was trabeculectomy. And now there are a lot of angle surgeries. There are both implants as well as excision surgeries. The implants tends to be more expensive. The angle surgeries relatively less expensive. There are various steps. You could start with a very economical angle surgery first, and once you get used to it, you can go for the more effective ones. So in this session, we'll learn why angle surgeries, for whom, when, how, what, all these things. So without much further ado, I'll start the session. And the first talk will be mine, where I'll give an introduction to the MIGS available here, intraoperative gonioscopy, and the 3D printed glaucomas, which is just the 3D printed glaucoma drainage devices and the 3D models which are available. Right. So, myself, Dr. John Davis Akra, glaucoma, cataract and refractive surgeon, and I'll be talking about MIGS, and we'll start with gonioscopy. We'll also cover Cahook dual blade, iStent, GAT, Tanito, and all the things which are available here, including other implants also. Okay. So MIGS, it is micro-invasive or minimally invasive glaucoma surgery. Some people call it minimally effective glaucoma surgery, but is it minimally effective? Yeah, some people are smiling. So some people think that it is minimally effective, but we will see whether it is effective or not. We will see which cases it is best done for, and then we will decide. Okay. So the 3D models here, these are models of some iStent and the Cahook dual blade, which I have drawn in 3D. These can be 3D printed as well. So no financial interest, but these are available for download, for putting in your presentations like this, or for 3D printing. Special thanks to Prasanna Venkatesh Ramesh, one of the prolific angle surgeons, and he's also doing a fellowship. He's giving out fellowship training for MIGS. Also, Dr. Sahiban Sethi is doing the same. So if you want to learn MIGS under a training center, these are the available options. You could also do MIGS training here. There is a Cahook dual blade training session in the wet lab here, free, so you can go and just approach them. So we will go ahead to what is MIGS. It is, most of the MIGS, it's an ab interno. From inside you go and do a minimal disruption of anatomy, unlike trabeculectomy or even NPDS. You don't cut out a lot of things. You just cut the trabecular meshwork. How much depends on the surgery which you choose. It is efficacious, star, asterisk, we'll get to it. High safety profile, yes. Ease of use, star, we'll get to it. Terms and conditions apply. Where does MIGS fit in? So we have medications. We have trabeculectomy, glaucoma drainage devices, cyclodestructive procedures. So MIGS and lasers, SLT, they come in between medications and surgeries. Not exactly not a surgery, but it is a much easier surgery. Again, terms and conditions apply. So why MIGS instead of medication? Patients on maximum medical therapy or with poor adherence reduce the medication burden and cause and all these side effects. So you can reduce the side effects. The ocular surface is better in case you want to do a trabeculectomy later also. The medications will worsen the conjunctival surface. So you need to preserve the conjunctiva. Do an MIGS. If or when it fails, you can go and do a trabeculectomy if that is what you like. And you have reduced need for daily eye drops, which is really a bad thing for quality of life. Somebody has to put drops every day for the rest of their life. Very bad quality of life. So that is also better, and allows surgeons to intervene earlier for milder glaucoma. You don't have to, think is it right time to do a trab or not. You can do it as early as you want. Prevents IOP fluctuations. So medication controlled glaucoma, always the IOP is up and down. It is not a smooth controlled IOP. So all those things are factors when you would switch from medications to MIGS. Why MIGS instead of trabeculectomy? It is a much faster procedure. Again, people are smiling. It is a faster procedure. It often works well. Okay, sometimes you get very good IOP control. It is not 1 or 2 millimeter minimally effective and all that. We'll get to that also. It is less invasive, definitely. No post-op discomfort of the bleb. Again, no confusion there. No blood-related or suture-related complications. No confusion. Even suture gap, no suture-related complications. Okay, no hypotony, does not damage the conjunctiva. You can plan tube or trab later. Okay, so some points some of you agree, some points some of you don't agree, and you would mostly do it in a mild to moderate. We actually do it in severe also, depending on the case. So mild to moderate, open angle glaucoma. Sometimes we do it in angle closure also, depending on the surgeon. And pseudo exfoliation pigmentary are very good ideal cases for it. Cup to disc ratio less than 0.8, ideally relative indication you can take for anybody. Pre-op IOP up to 30, okay. Target IOP you can expect maybe 15, don't expect much less because it's not trabeculectomy. You're opening it to the trabecular mesh, to the Schlemm's canal. Phakic, pseudo-phakic, doesn't matter, you can do it in both. You can do it combined, you can do it just as a single procedure in a phakic patient also if you have to. Okay, difficulty in taking medications, side effects of the medications, poor compliance, all these patients would benefit from an angle surgery. And what types of MIGS? All these are available. So what is available in India? iStent is there. Hydrus has just come last month. It has just come. So maybe it will come everywhere in India in the next 2-3 months. All the others, implants not here. CyPass was withdrawn because of endothelial cell loss. So yes, it is a new procedure. You can expect unexpected complications. And this side, all the trabecular excision. So bang, KDB, GAT, that is suture GAT, all easily available. HFDA is also available. It comes along with the Earthly phaco machine. You can get that. Tanito microhook also available. Some other microhooks also available. So all these are available in India right now. Zen gel stent looks like this. It is actually going all the way to the subconjunctival space. Hydrus is an implant which goes into the canal. iStent opens into the canal. This is the old iStent. This is the just previous iStent. The new iStent has a wider base, so it doesn't slip in. CyPass was withdrawn. And these are the excision procedures. This is the suture GAT, little difficult maybe to start with, but it does a 360 degree. So some people might call it a maximally invasive MIGS. Trap 360, trabectome, Cahook dual blade. So trabectome is, it was there earlier, but now I'm not sure if it is available in India. KDB now available. Endoscopic cyclophotocoagulation also available. If you want, you can get the machine, very expensive though. So this is what the KDB glide looks like, and this is what the iStent inject looks like. This one implants a device. This one cuts the trabecular meshwork. And this is about the 3D printed MIGS. You can download the designs from here. You can just go to this website, download a 3D model from here, ask your local 3D printing shop to print it for you. If you cannot find your 3D printing shop, ask your engineer friend or your dentist friend. Dentists have 3D printers. 3D printers are not expensive, so 15,000 you can get a 3D printer. Yes, you can buy one, no problem. This is how you can use the 3D models for just demonstrating to patients or students. This is all free software, Merge 3D. You just download a software, put this and you can use it. So that is the Glaucoverse. So we spoke about these. These are the things which are available. So the Georgia microhook is the one which I missed. All these are available in India. Bang is done with a needle, 2 rupee needle, 3 rupee needle. Just bend it, use it. Very easy. So we already spoke about which patient we do it in. I'll go ahead to which lens. So I use these lenses. So iPrism SX is a hands-free lens. Catena is a hands-free lens. These are disposable lenses. TVG is the autoclavable lens. So disposable lenses should not be reused, but some people do reuse after ETO, but should not be reused. And Swan Jacob Vogue surgical gonio lens, these are glass, you can autoclave them. And intraoperative gonioscopy, you should practice intraoperative gonioscopy, and you practice the gonioscopy, go with the Sinski hook or something, go to the angle and come back to get the hand-eye coordination, because it is little different. So this is about the lens, and I will go to the procedure itself. Procedure, you have to tilt the patient. So sorry, this has to change to, yeah, I have to play the video 1 second. Yeah, so we put the viscoelastic, cohesive viscoelastic, sodium hyalurate 1.6%, put the lens after tilting the patient's head away from you and tilting the microscope towards you. So I missed that part, that is in this previous video. So okay, somehow that part of the video is not here. So you tilt the patient away from you and then tilt the microscope towards you, 40-30 degrees. We will be covering that part also. And then you put the viscoelastic and then put the lens and then you visualize. Then when you go in, you can go into the angle. Microscope, you need a tiltable microscope. So make sure you have a tiltable microscope with tiltable oculars also. So microscope itself, body of the microscope itself should be tiltable. Eyepiece should be tiltable up so that it is comfortable for you. It is possible to do it in an uncomfortable position, and without tiltable microscope, some people are doing it by tilting the patient much more. Not ideal, but can be done. Very difficult to do though. This is ideal. Okay, continuous zoom and all that. And I would do combined preferably. You can do in pseudophakic easily. You can do in phakic with some difficulty. Right? And before or after phaco, I prefer before phaco, and you can do it after also. I prefer before, because then during the phaco some bleeding comes, and then towards the end of the phaco you have given enough time for the bleeding to stop. If you do after phaco, you might have to wait some extra time to let the bleeding stop. And these are the pre-op considerations. Normal, you just follow these. Positioning, yeah, this is the positioning video. So I'll just finish with the positioning video. Tilt the oculars also. This is the body tilt of the microscope, and now the oculus tilt is like this way. Okay, and then comes the part about putting the lens. Okay, I put the lens part first. Right. Where is it? Yeah, you turn the patient's head away from you. So in some of the next videos, we will be covering that. And the concept is you get an en-face view, so that you don't look at the angle at an angle. You look at the angle like end on, not end on, face on. Okay, that is on-face view, not at an angle. Angle should be not at an angle. You could get some hyphema, you could get some decimate detachment, decimate tears, and that is it. You wouldn't get hypotony in most cases. That's all. Thank you. Right. So next we will have Dr. Mahesh Bharati. He has to go for another session also. So we'll just have him talk about just GAT to do it. So GAT is, go ahead Mahesh, GAT is what?
Gonioscopy assisted transluminal trabeculotomy. The idea was to cover all the smaller procedures first and then go ahead with a 360 procedure, but then I have to go for the OPL session next. So I'll be talking about what, why and when. As Dr. John already said, it's a minimally invasive glaucoma surgery, minimal trauma to the target tissues, faster operating time, modest efficacy, high safety profile, and rapid recovery. This is the glaucoma armamentarium that we have along with us as of now. The traditional glaucoma surgeries on the right hand side and the micro-invasive glaucoma surgeries on the left hand side. And I will be talking about the GAT procedure, which comes in the excising or cleaving the trabecular meshwork. Developed by Dr. Grover and his team at the Glaucoma Associates of Texas, it's a non-bleb forming MIGS procedure, conjunctiva sparing, it's an ab interno, and 360-degree trabeculotomy. That's a major advantage, that it achieves a complete 360-degree cleavage, and it can be done either by an illuminated catheter or a suture based, where we use a 50 Prolene suture. So this is the microscope rotation, and so we mark the microscope, we trying to achieve a 30 to 45 degree bend of the microscope head, and we mark it so that when the two pointers coincide, we know that it is 30 degrees. So that you don't have to mark it every time. You mark it and keep it, and every time you do it, it's aligned. And then there are specific apps which are available. This is for the iOS, which is the measure app, which can measure the 45 degree angle. You have same for the Android also. A few tips to identify the trap meshwork. Nothing beats like a preoperative gonioscopy in your OPD. You don't want to have any surprises. So you should be very thorough with your preoperative gonioscopy at the OPD. And then one is by looking at the pigmentation, moderate to heavy pigmentation, especially in PXF and pigment dispersion syndromes. You will not have any difficulty in localizing the trap meshwork. But if it is not, if it's a lightly pigmented trap meshwork, you can use trypan blue to stain the trap meshwork. It stains beautifully, and you can visualize the trap meshwork. And then you can actually do something called as a provocative gonioscopy, or you can put the patient in a reverse Trendelenburg position and make the blood flow towards the head and see the blood in the Schlem's canal and visualize the trap meshwork. Patient selection is pretty same for any of the MIGS procedure. Like the indications are for primary and secondary open angle glaucoma. You can do it around either standalone or with a cataract extraction. Better to start with controlled intraocular pressures, at least on 2 medications. To start with, do for mild to moderate disease patients. Absolute must is a pre-op gonioscopy, and practice few sessions of intra-op gonioscopy in your routine cataract cases. So this is a routine cataract case. At the end of the surgery, you put your gonio lens, visualize the angle, see the trap meshwork. See the Schlem's canal, that is the blood in the Schlem's canal, you can visualize that. And below that you have the trap meshwork. So take your Sinskey hook, go there and just touch it and see. That will help your hand-eye coordination. Before you actually do your MIGS procedure, practice this. Now that's a movement that we are going to do for a KDB glide. We mark it and move it ahead, so that you can practice it before even you start your surgery. You can do it in your routine cataract cases. Now, whether to do it in combination or with a standalone cataract extraction, you have to explain the consent, detailed consent, because patient will be expecting a faster recovery in a cataract surgery. But because you are doing a MIGS procedure, especially with GAT, you can expect a lot of hyphema, and the recovery may not be as smooth what a patient expects after a cataract surgery. Though the hyphema will clear in a week's time, you have to explain it to the patient that your clarity of vision will take some time. And when you do a standalone procedure in a phakic patient, you will have to use pilocarpine in the anterior chamber to constrict the pupil. That will help open up the angle and improve your visualization, and also prevent the anterior lens capsule from any inadvertent trauma while you are manipulating inside the eye. And which to do first, they have done actually a RCT and compared whether do it first or after the phacoemulsification, and there is no differences. When I do it before the surgery, just after making the rexes, so that during the surgery, if at all higher grades of cataract, you get corneal edema, that will impair your visualization of the angle when you do it after the cataract surgery. So this is about the positioning. We said patient's head tilted away, the microscope tilted towards you, and as compared to a phacoemulsification where you do a bimanual procedure, both the hands are working inside the eye. Here you should have a good hand-eye coordination, because your one hand is going to hold the gonio lens, which will be outside the eye, and the other hand will be manipulating the instruments inside the eye. And you don't want to put any pressure with your left hand or your right hand holding the gonio lens onto the cornea, which will create folds on the cornea and again impair your visualization. That is the major difference that you work with. And also one more thing is, if you are not in a comfortable position or your instrument does not allow you to bend the microscope, like John said, you might be sitting at a lower level to watch the angle, and that would be also again discomfort. This is a major cluster of instruments, that is what we use it for trabeculectomy, and then you just compare it with the instruments that we have for MIGS. We don't have major instrument, especially for GAT procedure. All that you need is a Grishaber forceps, a gonio lens, and this humble 50 proline. So we use a normal cautery. You have you have to make the mushroom tip of the suture so that it does not hurt your trap meshwork. Now you can, when you compare it with the mushrooming tip, you can see that there are two types of mushrooms available here. One is a small mushroom and one is a bigger mushroom. We don't want to have a bigger mushroom because that will not go into the Schlems canal. You just need to make a very tiny mushroom which is sufficient enough not to cause trauma to the trap meshwork. So wound construction, we have to avoid the limbal vasculature because we don't want any bleeding onto the corneal surface that is going to mix with your viscoelastics that you are going to put on the corneal surface and remain there and impair your visualization. A 2.2 keratome incision is more than enough. A temporal incision is what we use for a cataract surgery, and the same incision can be used to approach the nasal angle, which is where we start our GAT procedure. About this tangential entry for suture entry, I will explain it when the video comes. So this is what I was telling about the tangential entry. So when we introduce a tangential entry like this, the suture comes to the nasal angle directly like this. Suppose assume you make an incision straight here and the suture comes here in the center of the eye. We have to take the suture from here to the nasal angle, and that will create a kink in the suture. And the kink in the suture will not allow the suture to pass very easily through the trap meshwork 360 degree. So we make an approach nasally towards the tangentially towards the nasal angle that will help the suture reach the nasal angle in an angle so that it traverses easily. Then once the suture is introduced, you visualize the angle and make a goniotomy. This is a well-made incisional goniotomy. You could see the posterior Schlems canal. The roof of the Schlems canal has been de-roofed. And then we pass the suture. Once the suture passes around 180 degree, you will get a slight resistance. You have to overcome that resistance and keep passing it. It takes around 25 to 30 single passes for the suture to travel the whole 360 degree and emerge out from the incision. And the first time that it emerges out, it's a wow time. You will have a goosebump feel. And then once it's out, you just have to pull it the outside with a McPherson and the inside with the Grishaber forceps and achieve a 360 degree trabeculotomy. And this is an intra-op surety that your procedure has been really successful. Can you see this whole area getting completely blanched out? That means that whole angle where that collector channels are there, they have been opened out, and that is letting your fluid go, and you have achieved a trabeculotomy. This is a case of post VR surgery glaucoma with silicone oil bubbles, unfit for trabeculectomy, planned for GDD, but then had an intra-op gonioscopy and the angle was completely fine. So we went ahead and did a 360 degree goniotomy. This is at the end of 6 months. You can see a nice cleft, all 360 degree. The cleft has been seen inferiorly also, and this patient maintains an intraocular pressure of 14 millimeters on single AGM for almost 2 years follow-up now. So advantages is achieves a 360 degree trabeculotomy. It's very cost effective as compared to any other MIGS procedures that we have at present. It's conjunctiva sparing. Learning curve is there. It's steep, but it's short. Take clinic message would be patient selection is the key. Intra-op gonioscopy plays a major role. Avoid limbal blood vessels. Tangential stab entry into the cornea to access the nasal angle. And finally, practice, practice, and practice. All this presentation that have been made is being published in the TNOA's guest appearance of guest article, and you can go through it. Thank you.
We'll have a quick photo before Dr. Mahesh. No, I'll also leave. So we'll have a quick photo and then we'll go on to the next talk. Sorry for the inconvenience, but we both have to leave. We'll have a quick photo. So next, I call upon Dr. Neetu Mohan. She is HOD of Glaucoma at Arvind Eye Hospital, Chennai, and she is the person who guided me into starting MIGS. So she will be talking about from bang to eye stent and microincisional trabeculectomy, trabecular cutting versus implants. Over to you, ma'am.
Good afternoon. So I'll keep this first talk a little short and just give an overview of these few procedures. And so iStent, I cannot say I have much first-hand experience on iStent. I have implanted only a single device. But to understand the device, it is a titanium biocompatible stent which works as a trabecular meshwork bypass. And this is the first generation iStent which had these retention arches to maintain it in position. And now what is available is the iStent Inject, which comes with 2 stents within the same implantation device. And this is the smallest implant ever designed for the human body. And as you can see, it can be implanted onto the trabecular meshwork about 4 clock hours apart. And this has additional outlets to enhance the flow of aqueous. And now we also have the iStent W, which is very similar to iStent Inject, except for that it has a larger flange diameter, which helps stabilize the iStent within the Schlemm's canal. And they're also coming up with iStent Infinite Zone, which will contain 3 devices within the same implantation device. So the outcomes of standalone iStent, what we can expect is about 20 to 30% of IOP reduction, similar to travoprost. So it may work well in mild to moderate glaucomas along with cataract surgery. And now, as John mentioned, Hydrus has recently been launched in India. And this is made from an alloy of nickel and titanium. And this essentially works by 2 mechanisms as opposed to iStent. This not just works as a trabecular meshwork bypass, but also scaffolds the Schlemm's canal and apparently keeps it open. But it is a much larger device and the learning curve of implanting this may be a slightly more difficult. So there are studies which have compared Hydrus microstent with phaco versus standalone phaco, and they have found that the IOP reduction with Hydrus with phaco is superior to that with phaco emulsification alone. And coming to BANG, bent ab interno needle goniectomy, I think most of us, when we started MIGS, this is what we all tried first. So you just need a 25 gauge needle, and it has to be bent very similar to how the Kahook dual blade looks. You bend it about 80 degree, just like how you bend a cystitome for rhexis. Okay, except for that, the bevel is on the inside. You bend the needle towards the bevel so that the outer aspect is smooth, and that protects the posterior wall of the Schlemm's canal. So the dorsal portion will be smooth. And you can also adjust the thickness of the goniotomy that you want depending upon where you bend the needle. So this is one of the earlier cases of BANG which we did. Currently, now that Tenito microhook is easily available, we don't do BANG much anymore. It is essentially the same technique, except for that since it's a sharp instrument, it can cut through the Schlemm's, through the trabecular meshwork and come out. So you need to keep inserting it again and again inside. So the other ways of doing MIGS may be much more easier, and so this here there was the trabecular meshwork did not completely get detached, so I had to go and cut it and remove it. So now this is one new surgery which we learned in the past year. This is microincisional trabeculectomy. This was initially proposed by Dr. Aparna Rao, and we had a workshop in Arvind Eye Hospital, Chennai, where she came and she taught us this procedure. The advantage is that all the instruments that we use can be reused. So this is her initial publication. The IOP reduction that we expect is similar to what we see in KDB or Tenito or BANG, except for that the incidence of hyphemas are much less. But you're actually going and cutting the trabecular meshwork, holding it and removing it, the incidence of hyphemas are much less when compared to other MIGS. So we essentially use the ab interno-temporal incision of the cataract surgery, and a goniotomy is done with a MVR surgical blade, and we use straight microforceps to cut two ends of the trabecular meshwork and then hold it with an end gripping VR forceps and remove it. So this is a short video of that. So after cataract surgery, a good amount of cohesive viscoelastic on the cornea helps good visualization. The patient is already positioned, and every time, as in any MIGS, every instrument goes in, you zoom out, and once you are in position, you zoom in. I have a good en-face view of the trabecular meshwork now. This is an MVR blade making an incision on the anteriormost part of the trabecular meshwork, just between the pigmented and the non-pigmented part of the trabecular meshwork. If you are in the right plane, there will be some amount of bleed. A cohesive viscoelastic is used to just remove that blood clot there. And again, the MVR blade makes an incision on the lower part of the trabecular meshwork, between the trabecular meshwork and the scleral spur. A good visualization is key, and a single sweep reaching up to the other end. Here you can aim for only 3 to 4 clock hours of excision. It is difficult to do a very large excision. And again, the hyphema is cleared using a cohesive viscoelastic. Now a straight micro scissors is used to just cut one end of the trabecular meshwork and then go to the opposite side and cut the other end also, so that now we have a free piece of trabecular meshwork there. Again, zoom out, cohesive viscoelastic to get good visualization. Now the end gripping VR forceps. The part that we have cut there, the trabecular meshwork can be gripped and just removed in a single piece. So the advantage is that the manipulation is minimal. We are just holding the trabecular meshwork and removing it, and this tissue can be used for any research purpose or any investigations that we need to do. So that is the blanching inferonasally. If you can see, there is a blanching that Dr. Mahesh was also talking about. Superiorly, we had the SC hemorrhage, so it's not very clear. And we try to put the blue also and see how much of flow is there. A bit of blue can be seen within the collateral channels also. So the advantage of MIT is it's a clean cut and removal. So we are hoping for a milder scarring response, less of hyphemas. It is very cost effective. There are no devices or stents involved, and the trabecular meshwork tissue can be harvested in this procedure. Thank you. I'll keep a few minutes from this talk for my next talk. Request Dr. Bindu to speak on Kahook dual blade goniotomy. She's a very senior glaucoma consultant at Comtrust Eye Hospital. Thank you, ma'am.
Thank you, Neetu. So we'll just go into Kahook dual blade. Nothing much about the instrument is all known to you. It's just the mechanism here is removing the trabecular meshwork. And the key features here are, it is a handheld knife designed to engage and stretch and then excise a strip of a trabecular meshwork. The specialized tip is the one which gives the dual action here. The pros and cons, it's favorably safety profile and fair good results are there, and versatile MIGS. It can be combined easily with cataract surgery. Now, when you compare KDB with other MIGS and goniotomy, the GAT and traditional goniotomy, again the trabecular meshwork is cut, torn or incised either within the suture, and trabectome, here again it is removed trabeculum with an electrocautery. Now in KDB goniotomy, what you do is, you remove the trabeculum, they say it is without causing significant damage to the surrounding tissue. Especially in trabectome, there is a lot of heat generated. Here, you cause less amount of damage to the surrounding tissue. Now, I think this part is being covered already. Now the prerequisite, yes, you do want to have a clear cornea, a cooperative patient especially without any neck issues, and then you have to stop the blood thinners, otherwise the hyphema part will be too difficult to manage. Whom you should not be doing is a patient with elevated episcleral venous pressure, angle neovascularization, or where you're not able to identify the angle definitely. Now we'll just go to the procedure. The first, you have to prepare yourself, know the landmarks, the anatomy of the angle. Yes, you have to be very thorough with it, and like previous speakers spoke about it, always after your phaco, practice the intraoperative gonioscopy and also know about your lenses. So this is what everyone had shown before. You learn to tilt the microscope and see how much tilt you require, and it's better to mark it. And then you have to tilt the patient's head 30 to 40 degree away from you. And the other thing what you have to do is, your microscope, when you tilt it, you'll have to look from down. So you have to, the eyepiece also, you have to lift it up so that you're comfortable in doing it. The marking which has already been told, and make sure it isn't like to get an on-face view, you align it coaxially, and then first you have a visualization of the angle, and then you try to magnify and view the structures. Which gonio lens? This advantage of Swan-Jacob lens is a one-time investment, and then you can reuse it many times. Though the other lenses are also reusable, but it gets damaged by multiple uses. This is the hands-free, where you get both the hands free to do the surgery, initial stages especially when you're not comfortable. And these lenses are a little bit on the pricier side also. And this is the glucose eye prism. Now first is docking, like I think I'll show in the video itself. So this is like when you're starting from a phaco surgeon, you want to be an MIGS surgeon. Of course, the first will be the tilt of the microscope. Patient positioning away from you. And also ask him to look away so that you get a coaxial alignment. Adjust the eyepiece, and now you are comfortable. And make sure your foot switch is also in a comfortable position. Cohesive viscoelastic over it, over the cornea, and then comes the docking, where you put viscoelastics into the eye. Then first, focus the angle first. Once you start visualizing it, then you can magnify it so that you get a better view. So this is how you will first start the gonioscopy. This is what we want, the angle which is looking at you, and first view. And this is the other lens, glucose prism, which gives you a wider area. Now what you don't want is a steep angle view. Here it becomes very difficult to do the procedure and to identify the angle structures also. You might not be in the correct plane. So that is what you don't want to see. You are struggling to get into the trabecular meshwork. This is the steep angle view which you don't want. In the initial stages, that is the learning difficulty. Now what are the other troubleshooters which you encounter during the initial stages? So that is when you are not in the clear cornea zone, which are the limbus, the blood from the section will ooze into the lens, and this can hamper your visualization. And in the initial stage, your hand starts pressing too much and you have the corneal folds again which can hamper it. So that steadiness, and also if you have air under the lens, your visualization becomes difficult. So these are the initial troubles that you can overcome by just doing practice multiple times. And most importantly, you have to identify the angle structures before you go into the procedure. This is the hook dual blade. So you identify the trabecular meshwork and then you start stripping the trabeculum. You can just move the lens and the eye so that you can get a wider angle also. And then you turn it and do the other side. So you can extend the angle also, like you can go tilt it and then do the maximum area you can cover it. So that is the collector channels which are exposed. You can put the visco and see if it is. So those are the bleeding vessels from the collector channels. So now we have completed. And then when you wash, you can see the free trabeculum which you have ripped. I just wanted to show the collector channel, but then I injected an air bubble there. See that trabeculum, you can just take a forceps, micro forceps, and rip it off actually. It just comes off. So that's, then you form the AC and the surgery is complete. So the most common complication is the next day you see hyphema and some amount of iritis due to that. I've been doing it since 4 years. I just had one case where the patient had little amount of hyphema, but after 1 week she came with a hypotony and I could see choroidal folds, and this was the ASOCT picture of her. She had developed cyclodialysis cleft, and then I could treat her by just giving atropine and steroids, and it got settled actually. That was one complication which I had. And these are some of our presentations, which one eye underwent trabeculectomy, in the other eye KDB was done. And another presentation again on goniotomy with KDB. Our pilot study, when we started, we wanted to look whether it is efficacy is there or not compared to the thing. It was effective. Thank you so much.
Dr. Lopamudra will be speaking on my experience with Tenito Microhook. She is a consultant at Chaitanya Eye Hospital, Trivandrum.
Thank you, ma'am. Ma'am was one of the mentor in Arvind. So I'll be talking on Tenito Microhook trabeculotomy. No financial disclosure. The current version of trabeculotomy has evolved from ab externo to the ab interno technique, which fulfills the condition of minimally invasive glaucoma surgery. So the ab interno trabeculotomy can be done by various methods, as already discussed, by KDB blade, Tenito Microhook, GAT, trabectome, and bang. So coming to the base choice concept, among the MIGS procedures, it should have a lowest IOP, highest success rate, lowest complication rate, and it should be cost effective, and it should give best vision, and so on. So among the incisional TM based procedure, though GAT has a very promising outcome, but it has a stiff learning curve, and the post-operative hyphema is common. Coming to the KDB blade, it also gives a very meaningful IOP reduction, but it is expensive. Same is with trabectome. And next is bang. bang is done with a bend 25 gauge needle, and the safety profile, the efficacy is doubtful. So why tenito microhook trabeculectomy? The first day of our cataract surgery, we are very much used to with this Sinskey hook, and the tenito microhook is very similar to a Sinskey hook with a specialized tip. The tenito microhook is very easy to learn, it is efficacious, it is economic, and it has a very good safety profile. And if the surgeon wants, he can do a more wider extent of trabeculectomy. So it can be started as a first MIGS procedure by the beginners. So again, the question being currently debated whether to preserve or remove all the trabecular meshwork. So sparing some of the TM Slem's canal complex may provide for another TM-based procedure in future. So a more limited trabeculectomy can give a balance between the IOP reduction and the preservation of the TM tissue. This tenito microhook is a specially designed microhook with a single blade oblique tip surface with a circular edge to cleave the trabecular meshwork and the inner wall of the Slem's canal. It comes in 3 models. The straight one is to approach the nasal angle, and the angle left and angle right, you can approach both nasal and temporal angle. If you compare the tenito microhook with the rest of the instrument, it is very thin and slender, and the tip of the hook is much smaller. So the anterior chamber manipulation is being easier. It allows the surgeon to assess all the quadrants of the TM if he wants. The another advantage is it is not disposable. It can be reused for countless times after sterilization. Again, if you compare the tenito microhook with rest of the procedures, it gives the opportunity to approach half to 2/3 circumference of the trabecular meshwork apart from gap, as you can see here. So this is the video. Here you can see this is the angle left and angle right hook. The angle left you can approach the superinasal angle, and the angle right you can approach the inferonasal angle. I usually do after the completion of the emulsification. So the anterior chamber is distended with the high molecular weight viscoelastic, and the Swan-Jacob gonio lens is used to focus the angle structures. And the tenito microhook is introduced through the 2.8 clear corneal phaco incision, and the tip is inserted into the trabecular meshwork, and it is moved circumferentially over the desired clock hours to excise the TM and the inner wall of the Slem's canal. And you can see here the white strip behind that represent the back wall of the Slem's canal. I used to prefer to do the superinasal angle first, then the inferonasal angle. And again, you can see that is a blood reflex into the anterior chamber, and the anterior chamber is washed, and the wounds are hydrated to form a watertight chamber. And after insertion, the tip of the hook, the depth can be monitored by looking at the tip of the hook. If you are in a deeper plane, you won't able to see the tip. And if you are in an adequate plane, and then you feel very minimal resistance while moving the trabecular hook. And you can see that is a blood reflux from the angle. And post-operatively, we give antibiotic for 2 weeks, and steroid drops tapering dose for 6 weeks, and non-steroidal antibiotic for 8 weeks, and pilocarpine for 6 weeks, depending upon the surgeon's choice. In our center, we have almost done 36 cases who has completed 3 months of post-op with mild to moderate open-angle glaucoma, which was medically controlled, and the baseline IOP was 13.19 with anti-glaucoma medication, and the number of anti-glaucoma medication was 1.33. The preoperative intraocular pressure was 13.19 with anti-glaucoma medication. At 3 months post-operatively, it dropped to 11.31, and most of them were AGM free. And the preoperative number of AGM was 1.33, and at 3 months post-operatively, 33 patients were AGM free, and only 3 patients were on AGM. And the common complications were hyphema, stromal edema, IOP spikes. And in my initial cases, I used to get there is a localized edema with bullae near the section. It is because of while taking out the hook, I used to get small DM strips. And all eyes has got a best corrected visual acuity of more than 6/9 at 1 month post-operatively. As you can, this is the post-gonio picture at 1 month post-op. And you can see here there is a trabeculotomy cleft in the nasal angle. And same thing is shown here in the SOCT. As I have already told, I have some few cases initial cases I have small DM strips while taking out the hook. If the tip of the hook is up, then I used to get like this kind of DM strips. So there is a study by Tenito et al. Where he described the effectiveness and safety of combined cataract surgery and micro ab interno trabeculotomy in 68 patients. The mean preoperative IOP dropped from 16.4 to 11.8 and the number of AGM 2.4 to 2.1 and the most postoperative complication was hyphema. A study by Sasidharan et al. Which was published in IJO, the short-term outcome of Tenito microhook trabeculotomy, which was combined with phacoemulsification in open-angle glaucoma in 30 patients. All eyes has a best-corrected visual acuity of more than 6/9, and the mean IOP was reduced from 23.57 to 17.33. But here, none of the patient was on AGM, and the post and IOP spikes, edema, hyphema, and IOP spikes. So to conclude, the Tenito microhook trabeculotomy is a safe and efficacious in mild to moderate open-angle glaucoma with relatively minimal complication. There is a moderate reduction of intraocular pressure with reduction of the anti-glaucoma medication burden with rare vision-threatening complication. It is cost-effective alternative to many TM-based glaucoma procedure because the hook is not disposable and it can be reused for countless times. So combining with cataract surgery is a valuable addition to the glaucoma surgical armamentarium in developing countries. Thank you.
Now we have Dr. Neetu speaking on evidence-based MIGS, for whom and for how long.
So since we have been speaking about how to do MIGS, I thought it's good to take 10 minutes to discuss why we should be doing MIGS, for which patients, when, and if there is any purpose at all in doing MIGS. And we are just going through some of the good literature that we have up till now. There is a lot of literature coming up every year. If you see, there are so many articles on MIGS. We are going to look at some important ones. So this is the first pivotal randomized controlled trial on the first generation iStent, the 2-year results. And they reported when compared to cataract surgery with iStent versus cataract surgery alone, there was a significant difference in the success outcomes, where success was defined as an IOP reduction of more than 20%. And they also found that the IOP as such between the two groups, there was a significant reduction. Now we had some discussions about CyPass and corneal endothelium. What about iStent and corneal endothelium? So this is a long-term endothelial safety profile with iStent inject in patients with open-angle glaucoma. This was an extended follow-up of the pivotal trial for iStent inject, of which 227 of the initial randomized patients were followed up over a long time. And they found that there was no significant difference in the mean endothelial cell density between the cataract group and the cataract surgery with iStent group. And this is a study which randomized patient to 1, 2, and 3 iStents each. And when the outcomes were compared, it was found that the use of 2 or 3 iStents had a better outcome when compared to a single iStent alone. So the presence of 2 or 3 iStents, the success rates were much higher when compared to a single iStent. And what about Hydrus versus iStent? Both Hydrus and 2 iStents were found to be equally effective in reducing the intraocular pressure, but Hydrus implantation had a slight advantage over a single iStent in this meta-analysis. Now coming to the Cahoog dual blade, we have already seen how the technique is, and the initial randomized study which compared Cahoog dual blade with phaco versus phaco, actually though they found a difference in the IOP control as well as the number of anti-glaucoma medications, this difference was not found to be statistically significant. But after this, there have been many retrospective studies, and this meta-analysis which took data from 26 studies and 1,659 patients, concluded that KDB with phaco had a superior IOP reduction of about 22.74%. Even then, it is modest. It may be good for mild to moderate glaucomas, whereas phaco alone, the IOP reduction was much less. Now coming to Tenito microhook, Lopamudra has already covered many of these studies. So this is the study by Masaki Tenito himself, in which he found an IOP reduction. The mean IOP reduction expected was 31%. And as we have already seen, Tenito microhook addresses a larger area of the trabecular meshwork. So it could logically bring about a superior reduction. It is possible. And this was his study. And he also compared outcomes of suture gap versus Tenito microhook and found superior outcomes with Tenito microhook. This IOP reduction as well as the number of reduction in anti-glaucoma medications in this study was superior with Tenito microhook. And we also have the study from Arvindai Hospital, Tirunelveli, where they found a mean IOP reduction of 51% with Tenito microhook with cataract surgery as opposed to cataract surgery alone. And the few studies that we have where toric IOLs have been combined with minimally invasive glaucoma surgeries are with Tenito microhook, and they found good outcomes similar to cataract surgery alone when toric IOLs were combined with Tenito microhook trabeculotomy. As far as BANG is concerned, there is very limited literature. This is one retrospective study of BANG where they found about 20% reduction with cataract surgery, when BANG is combined with cataract surgery in about 70% of the patients. And this randomized control trial, which compared BANG with suture GAT, they found that BANG was definitely inferior to suture GAT in terms of IOP control, complete and qualified success, as well as a reduction in anti-glaucoma medications. Coming to gonioscopy assisted transluminal trabeculotomy, this is the 4-year surgical outcomes of GAT in a significant large number of patients, and what they found was the cumulative failure rate at 4 years with suture GAT was 53.9%, and what is a little more concerning is the cumulative reoperation rate was 42%. So how does this fare when compared to trabeculectomy? So if you look at the primary tube versus trab study, at the end of 5 years, the cumulative probability of failure was 35%. So compared to trabeculectomy, probably GAT did a little worse, but then there is an advantage that the superior conjunctiva was preserved in these patients for a future surgery. Now comparing 360 degree, 180 degree superior or 180 degree inferior GAT, the outcomes were similar. There was no added benefit of 360 degree GAT when compared to 180 degree GAT. This was a randomized control trial with a 1-year follow-up. And as expected, the rate of hyphemas were significantly less in 180 degree GAT when compared to 360 degree GAT, and the IOP spikes were also much less. Now, what is the role of minimally invasive glaucoma surgery in primary angle closure glaucoma? I don't think we still really know. So though goniosynovial does not really come under the purview of minimally invasive glaucoma surgery, a lot of research has been done on GSL. And this meta-analysis concluded that GSL does not give additional benefit in primary angle closure glaucoma. So there is no additional benefit in combining it with a cataract surgery. So this is the only randomized control trial of GAT in primary angle closure glaucoma. And they found similar outcomes with phaco GAT as well as phacos. And the success rate of phaco GAT was 94.5% when compared to phaco, which was 86.8% of complete success, and this difference was statistically significant. The outcomes were superior with phaco GAT when compared to phaco emulsification. And hyphema and FM were the common complications in phaco GAT. And this delayed visual rehabilitation with phaco GAT did not affect the final visual outcome. So phaco GAT was found to be more beneficial than phaco emulsification alone. So as far as MIGS in PACG goes, the available evidence suggests that cataract surgery in combination with MIGS can be safely and effectively performed, but these are largely based on retrospective studies and small RCTs. Now the big question of all, trab versus GAT, should we be stopping doing trabeculectomy at all? There is not much literature on this if you look at the good quality studies. This is a single center retrospective comparative cohort study which compared standalone GAT versus standalone trab. And they defined success as an IOP reduction, which is much more significant. That is at least a 30% IOP reduction. And they found that complete and qualified success. With TRAB, the complete success was 59%, and with GAT, 46%. Re-intervention was higher in GAT as compared to TRAB. So what this study concluded was that at 18 months, GAT was as effective as TRAB in reducing intraocular pressure. This is over a 1.5 year follow-up. And TRAB, of course, provides a greater IOP reduction than GAT, but ab interno trabeculotomy is less invasive and spares the superior conjunctiva. In juvenile glaucoma and congenital glaucoma, there is not much of consensus. GAT is known to do fairly well in juvenile glaucoma, but Cahoog dual blade goniotomy not so much. Whereas in congenital glaucoma, both Cahoog dual blade goniotomy as well as GAT have been shown to have good outcomes. So normal tension glaucoma, there is no definite advantage of combining a minimally invasive glaucoma surgery with cataract surgery. Cataract surgery alone does well. And as far as secondary glaucomas, like silicone oil induced glaucomas go, there are very few studies and just a few case series to know the outcomes. I will end up with this meta-analysis which compared combined microinvasive glaucoma surgery with phacoemulsification. So this study divided the minimally invasive glaucoma surgery into 3 groups. One is the trabecular meshwork bypass devices like iStent. 2 were non-GAT goniotomies that remove the trabecular meshwork. And the third group was GAT, either done with a catheter or with a suture. And the IOP reduction was the best with GAT, which is about 9.35 millimeters of mercury, as opposed to 3 to 5 millimeters of mercury with devices or the other ways of doing minimally invasive glaucoma surgery, like Tenito or Cahoog dual blade. And all MIGS groups had equal or lower rates of sight-threatening events and secondary glaucoma surgery when compared to control. GAT had the highest incidence of 5 FEMAs. So based on this study concluded that based on the current peer-reviewed articles, there is strong evidence that when compared to phacoemulsification alone, combined phacoemulsification with MIGS is beneficial for patients with open-angle glaucoma and does not increase the incidence of vision-threatening events. Thank you.
Requesting Bindu ma'am to hand over the memento to Neetu ma'am.